What's going on, everybody? This is Dr. Owusu-Akyaw with OrthoVirginia. I'm one of your sports medicine specialists, and I'm just so happy to be here with you today talking about hip arthroscopy, hip injuries, and how it pertains to sports medicine. I'm part of OrthoVirginia's Trader Road team, and we're very happy to take care of the community and help prevent injuries as much as we can. I'm going to give you kind of a more holistic and broad view of how hip and hip mobility plays into important topics in sports medicine. So I want to introduce my team. And for those of you who haven't met me in person, I'm all about team dynamics. I got to tell you, nothing that I do is possible without my incredible team. We've been honored to be recognized as one of the top 1% nationwide for patient outcomes as it pertains to hip and knee injuries. And I have to thank Sherma Francis, Jen Beach, Devontae Bryant, and Danielle Judkins for making that possible for our team. This is the last 2 years in a row we've gotten that honor, and we're going to continue to be a good steward of that honor. You know, we're pleased to take care of very high-level athletes at all levels in the community. We're taking care of people from University of Richmond, the athletic department, taking care of the Richmond Ballet, another group of top athletes. And of course, in the community, we're active taking care of people from the high school level and on. So it's just such a pleasure to be part of this community and to serve in this fashion. So all that to say, a little bit of a shameless plug. Very recently, OrthoVirginia put together a community impact seminar on August 9th. It was hosted at the new Henrico Sports and Events Center. And on August 9th, we called this seminar the Prevent, Protect, and Perform seminar. And we're really emphasizing how important injury prevention is. And this is a bit of a side from my talk about hip arthroscopy, but you'll see I'm going to tie it in later. We don't really think about or respect sometimes the long-term effects of sports injuries. Sports injuries really do cause a long-term effect on people. We think about the short term, and it's easy to kind of think about, well, someone gets injured, maybe they have surgery, maybe they don't, but they recover and they come back and everything's back to normal. And what we're not accounting for in our mentality is the long-term effects of that injury. If I take like an ACL tear, for example, someone tears their ACL, you've seen it on ESPN, you've seen it on the news. They go surgery usually for a high-level athlete. They go through a period of recovery, rehabilitation. They build through that, and then they come back and they play again. Sometimes. We have to recognize that some people will not make it all the way back from such a severe injury. And even those who do may suffer long-term consequences like knee osteoarthritis, changes in the way they can move about that could affect them throughout their whole livelihood. That could affect future occupational opportunities, job opportunities, and just quality of life overall. All that stemming from this injury. So the more of these injuries we can prevent on the front end, we're really creating an incredible community impact. And that's what I want to see sports medicine become. I want to see sports medicine really integrated with community impact, and I think we can do it. So this event was an incredible testament to this. It's actually the second year we've done this, the second annual event. And it was the biggest one yet, of course. We had individuals from the community, local coaches, several individuals who played at the professional level of football, people who played Division I basketball and football to come talk to our group. We had physical therapists from OrthoVirginia and throughout the community. We had my own team there to help present and kind of teach. I think it was great. So a little shameless plug. Look out for this. It's an annual event. We hope to see you there next year and to make it bigger each time. So I want to take a second to step back and really tie hip injuries in with injury prevention. So this is a study done at the Hospital for Special Surgery where I did my fellowship. And what they found there was that athletes who have restrictions in their hip mobility had a higher risk for injury of their ACL. Now, as you know, the ACL is a critical ligament inside of the knee that holds it stable. So I drew a diagram over there to the right. I didn't draw it, but I put it together for y'all. And you can see a picture up top, of the top right, a cartoon of a hip joint. And so a lot of times people get the hip joint wrong in terms of where it is. People say, put your hands on your hips, and they put it on their side. And really, you're pointing at your iliac crest. Your hip joint to an orthopedic surgeon is the ball and socket, which is down deep in the joint. And so in my picture here, you can see a picture of the ball and socket. with the cartilage of the joint being colored in purple, and it's being surrounded by the labrum, which is a special ring that holds it in place. Now, the ball and socket is made up of the acetabulum, which is the socket, and the femoral head, which comes off the femur, the thigh bone. And so what I'm trying to illustrate for you in this picture is mobility of that hip affects how stable your knee is down below. Following the arrow down, you can see a diagram of a knee that's been opened, so to speak, and you can see the ACL colored there in pink. In the one picture on the left, you see an intact ACL and a torn one on the right. Now, I make this connection because we think frequently about things like ACL tears, but we don't always think about the causative effects. And one of the causative effects, like this study shows us, is that poor mobility of the hip can lead to excess force in how someone moves. I should say abnormal force in how somebody moves. And so when they're doing that high level cutting and pivoting activity that is so critical for sports activity, they're putting the rest of their joint at risk. And you can see what follows. So, we see the after effect, the ACL tear, the meniscus tear, the PCL tear. But we don't always think about the larger picture, which is overall mobility and joint health. Joint health of the hip helps to control the rest of the body. We also think about things like what we call neuromuscular control, which is really just a way of describing how well can your muscles protect your joints. Are your muscles strong enough to protect your joints for the activity that you are doing? So we need to put an intentional focus on these other aspects that come together to potentially be causing this epidemic of injuries we've seen in the knee. We can keep going. So I'm going to focus back in on the hip joint. So like I was saying before, there's some misconceptions sometimes about what the hip is and what the hip isn't. And anytime I'm counseling a patient, I want to help them divide it into buckets. And I find that binary buckets, just two buckets, makes things the fastest and the easiest. So we have intra-articular and extra-articular hip pain. Like I told you before, the actual orthopedic anatomic hip joint is down deep in the ball and socket. And usually, like you see this young man pointing in the picture, usually when someone has pain in that hip joint, it will be down in the groin. It'll feel like it's down in the groin. Now that's important because a lot of times what are actually hip injuries are misdiagnosed as other things, which are near the hip. Things like hip flexor injuries, groin injuries. Listen, I can't tell you the number of people I've seen who had a hip injury for years, but have been told forever they had just a groin pull and were blown off. So it's important that we really speak about things correctly and with the right vocabulary. What I want you to have is the right vocabulary to be armed so when you walk into the doctor's office, the communication is easier, all right? So again, going back to our buckets, intra-articular hip pain is pain inside the hip joint ball and socket. So that usually hurts in the groin, and it usually hurts with rotation and flexion of the hip. So the diagram on the left, you can see a cartoon of a doctor performing what we call the fader maneuver. That fader maneuver brings the hip joint into flexion and internal rotation, like you can see there. Now, typically, if someone with hip pain is having pain from their hip joint ball and socket, that maneuver hurts them right in that location. Now, everybody's different in how they experience pain. So what we're describing here is what's average, but it doesn't always go that way. But if we see someone has a positive fader, FADIR examination, we're concerned for something intra-articular. Now that could be, you probably heard the term labral tear, and that's an option, but I want to be clear, having a positive fader does not mean you have a labral tear necessarily. We don't know that. We know something's going on inside your hip joint, which could include a labral tear, could include hip impingement, could include hip arthritis. We don't know until we get further imaging, but the physical exam usually comes first. That's intra-articular. Now, if we talk about extra-articular, the best way to think about that is thinking about things that are around the hip but are not in the hip. So frequently people have complaints of things like bursitis. So that's kind of to the side of the hip. If you look again on the diagram of the young man, where it's pointing at and says not the hip, it's pointing to where a lot of people have pain when they have bursitis. So lateral or to the side of the hip, injuries to the gluteus, bursitis, injuries to the hamstring can be around there. You can have injuries to the hamstring down by the ischium, the bone that you sit on, right? And though though it's close to the hip and it feels like it's around the hip, it is not inside the hip joint. So when we're talking about hip arthroscopy, typically we're talking about treating things that are inside the ball and socket, intra-articular hip pain. There are other things to be done to treat extra-articular hip pain, but that's kind of a separate lecture. So again, breaking down the anatomy. I know I sound like a broken record, but repetition builds mastery. So we're looking here at the top left of a picture of a patient's pelvis. And you can see coming from the top down, the pelvis joins with the spine, the lower part of the spine. The acetabulum, the socket, is sitting there as basically an adjoining segment to the femur. And that joining segment is the hip joint. So once again, thinking about anatomy, there are effectively two important types of cartilage inside of the hip joint. Both of these can be a cause of pain and potentially symptoms, intra-articular symptoms. So on this diagram, looking at the blown up picture to the right, you can see the ball of the socket. You can see the labrum, which I've highlighted in kind of a hot blue, a teal if you want, that's going around acting as a suction seal. That labrum is a special type of cartilage. It's kind of harder than the typical cartilage you think of, and kind of what we call fibrous. It's meant to hold a suction seal on that joint and therefore confer some stability to the joint while it's going through its range of motion. Now, the hip is a very mobile joint, more mobile for some than others. Some people can put their ankle behind the head and all that stuff, and some people can't even cross their legs, right? But even with that, people are moving their hips throughout the day. You sit, you stand, you walk back and forth, you run, you exercise, you hip hinge, you do hygiene, use the restroom. All of that involves movement of the hips. So the hip is central to almost everything that you do. So the labrum is one type of cartilage. And then you have the articular cartilage, which is more of like the bearing surface of the ball and socket. I've colored that in purple for you here. That's similar in makeup to the labrum, but a different, let's say, function. It's acting to act almost like a bearing between the bones of the acetabulum and the ball. And so that type of cartilage, that articular cartilage, is what is affected primarily when someone has hip arthritis. So you may hear the term bone-on-bone arthritis is thrown around a lot. What they're saying is that articular cartilage, which is purple in this picture, is worn away such that the bone is on the bone and there's no cushion in between. Both of those, bad arthritis and a labral tear, would feel like intra-articular hip pain. And that's why I say we need to break things up into bigger buckets, because we don't know the full diagnosis until we've gone through the diagnostic process. So going once again, ball and socket of the hip joint has the labrum going around. Now, one of the most common things I treat surgically is a tear of that labrum. So like we said, that labrum goes around the ball and socket, holding a suction seal on the joint. That's its main purpose. And so for some people, if there's a big enough tear or a tear in just the wrong place, that will lose the suction seal on the joint. When that suction seal is lost, it can cause for some people a micro instability, which then causes pain in certain situations, especially at the end range of motion. So frequently, the pain related to a labral tear, is due to micro instability and not so much the tear itself, although that can be a cause of pain. It's a secondary effect, so to speak, of a larger picture. There is an entity, a phenomenon called femoral acetabular impingement, or hip impingement for short. People call it FAI sometimes. And what that is when there are changes around the ball and socket that put the cartilage, both the articular and the labrum cartilage, at risk. So looking over here at the top right, you can see a hip joint, a typical hip joint sitting ball and socket. And what you'll notice is that they fit congruently together. Okay, they fit like a ball and socket, as they should. There's nothing irregular. They fit like they'll move together. And when that's the situation, that allows for a full arc of movement. Looking down at the bottom, the left and the right, you can see there's an extra bit of bone, like a red bump on the left where it's on the ball, and on the right where it's on the socket. Now that is what hip impingement does. When someone has that extra bone, that bone interferes with the arc of movement of the hip and limits how it moves. And you can see in the picture here how it might even bump on the labrum. And through repeated injury, repeatedly moving that hip, that bump keeps hitting a labrum or squishing it and causes a tear. So this hip impingement, this FAI, is frequently the underlying cause for someone who has a labral tear but does not have arthritis. Now, it's a complex thing, FAI, but it has two big buckets since we're talking about buckets. There's the cam impingement bucket, where the bump is on the ball. There's the pincer impingement, where it's on the socket. But in either case, the cause, or rather the outcome, is the same. For some people, that bump will interfere with how the hip moves and therefore limit motion and cause injury to the hip. And then remember what we said in the beginning. Loss of hip mobility can also predispose to other injuries down the line, like the knee, like the ACL. So this is a big and important concept to understand. And it might be an underlying cause that we can maybe try to use to understand better and prevent more other injuries. So a lot of times patients come to me with an MRI in hand already. They say, look, I have been diagnosed with a labral tear. I have hip impingement, that FAI. My hip hurts, interfering with my quality of life. I need surgery right away. What I'm going to caution you about is that in pretty much every circumstance, surgery is the last resort. While there are times we do surgery on an urgent basis and we kind of get to it quickly, there really are a lot of times when we could try to avoid it. Now, the most common question I'll get then is, well, doc, if my labrum's torn, how can it be fixed without me having surgery? So I'm going to start over here on the left. Remember, I told you, one of the principal reasons someone's hip hurts from a labral tear is because of possibly the micro instability that it causes on the hip joint, the inability to move to the end range of motion to rotate without pain. So the question is, if we're not worried about the labral tear itself, but rather the stability, if we treat that stability, a lot of people will feel better. So some studies show as many as 80% of people will be better with physical therapy to strengthen the muscles around the hip joint, right? Strengthen those muscles, those key stabilizers around the hip joint to stabilize it and cause the body to feel secure of the hip joint. And if that works for you, you can ride that out forever. You never have to have surgery unless the symptoms interfere with your daily life. So in the picture to the left, I show an example that kind of demonstrates what I'm talking about. Now, the gluteus muscle, I think most people are familiar with the gluteus muscle. I'm not sure everybody knows that the gluteus kind of comes in three parts. There's a gluteus maximus, medius, and minimus. Now, the gluteus maximus gets all the love. It's the one people think about when doing squats, leg press, the whole bit. And the gluteus medius and minimus together are actually important pelvic stabilizers that don't get talked about enough. And they're frequently weak for patients. They're frequently weak. Even people who have never had an injury, they'll have weakness in that muscle. And I think that has something to do with our society, how much we sit, but that's a whole nother digression. That gluteus medius, if strengthened, as you can see in the picture, can confer a sort of stability around the hip joint. And so while the labrum won't be fixed without surgery, that may be true, we can make it so maybe it's not so impactful on the patient and therefore they can get through without having to have surgery. And so that's a long way of me saying that every patient who has a labral tear hip impingement situation needs to try conservative, meaning non-surgical treatment first. And the centerfold of that is going to be physical therapy. Now, I've got some pictures here of what happens if that doesn't work. So flipping over to the right, you see the diagram going from left to right, a normal labrum sitting as a suction seal like we expect, a torn labrum, like we talked about, loss of a suction seal, and then on the right, there is a repaired labrum. So in that situation, we've gone in arthroscopically, meaning 3 small holes around the hip, and put tiny little anchors or plastic screws, if you want, into the bone, with stitches coming around that go around the labrum, and then basically, I call it zip tie it back in place. Now you can look onto my website on the OrthoVirginia portal. You can see I got some demonstration surgical videos if you want to take it that far. But the cartoon really gets the point across. So we're basically putting the labrum back in place. Mind you, we're putting it back in place to heal. Orthopedists were gardeners, not carpenters. So putting it back in place does not automatically equate to healing. What happens next depends on the body to heal it. At the same time, we're going to then smooth out any impingement that we see. And again, you can see my videos on the website about how that's done, what it looks like. We will smooth out that extra bump of bone so it doesn't keep on hitting the labrum. In that case, we treated the underlying problem, the labral tear, and the underlying cause, the impingement, both together. And like I said, that's an arthroscopic surgery, which I found some people get twisted to think that means that it's simple. I want to talk about that real quick. Arthroscopic surgery does not equal small. It just means it has small looking incisions. Does not mean it's a minor surgery. This is a major surgery. We're looking at protected weight bearing, by which I mean to say usually crutches, on the order of 4 to 6 weeks. For a given patient, there could be utilization of a hip brace during that time period. Any kind of high impact, running, heavy lifting, on the order of 3 months after surgery tends to be the average. Full return from this surgery can take 6 to 12 months. Now, when I say full return, what I'm talking about is returning to the high level activity that might have caused the problem in the first place. So if we're talking about one of our high level athletes and they have this situation, they fail conservative treatment, and we make this shared decision together that we're going to go through a surgical journey together, we're looking at 6 months likely minimum to return on the field or on the court. All right. But even then, remember, return to sport is not one moment in time, but rather it's a process by which people gradually reintroduce activities. So this is a really, really real commitment. And so I impress upon every patient who I see with this problem, I need you to think about this situation globally. And don't think about this as a quick fix, but rather an opportunity to work together on resetting your hip mechanics and then building strength and stability along with mobility for a lifetime. I think that's the last slide I have. Do we have some questions I need to answer?
Thank you so much. It is the last slide, and we do have some questions. So we will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will do as many as we have time for. So our first question is, how much rehab or physical therapy is needed after a hip arthroscopy?
It's going to vary by patient. It's going to vary by what your goals are. But on average, I tell patients between 3 to 6 months. The first 3 months is really just trying to restore you to kind of like a regular activity level, being able to walk long distances. Some people run. For people who are going to be a little bit higher level, or for some people who might have maybe a slower disc recovery for other reasons, it's more in the order of 6 to 9 months. That rehab is foundational, by which I mean to say it starts off very, very basic, just like waking the muscles up, and then it becomes stronger and stronger. And so with time, it becomes more like a workout. And so by the mid portion, you're going to the physical therapist really to like go to the gym, so to speak, and get strong around your joint. But a short answer is about 6 months on average.
Thank you. Is there an age limit, an upper age limit or a lower age limit for a hip arthroscopy?
That's a great question. It comes up a lot. There isn't technically a number chronologic age limit, but there are some factors to that. So on the lower end, the preference is that someone has their growth plates closed, i.e. their bone is done growing before undergoing a hip arthroscopy. It won't always go that way. It's not always possible. But if we can, we prefer that, because there's drilling into the bone that occurs and we don't want to disrupt any growth process. On the other end, previously there was a conception that people of a certain age could not have a hip arthroscopy. And it's not strictly speaking about age. It's a question of how well preserved is someone's joint. You might recall I talked about articular cartilage and arthritis. And so people who have lost a fair amount of their cartilage in their joint, which tends to happen with age, are not going to do well with a hip arthroscopy. And I say that because if you go back to the intra-articular hip pain conversation we had at the beginning, your body can't tell what's making your intra-articular hip pain hurt. And so you may have a labral tear, but if you also have arthritis, i.e. loss of the articular cartilage, me fixing your labrum is not going to fix that cartilage issue. Nothing will, outside of a hip replacement, which is another story, right? And so we have to be careful about applying the hip arthroscopy appropriately. If you have arthritis and I fix your labral tear, you're probably not going to feel a whole lot better because you'll still have arthritis when I finish fixing your labral tear.
going off of that, can you just give a brief compare and contrast of how a hip arthroscopy is different from a hip replacement?
I think it's a great question that comes up a lot as well. Two different mentalities, two different ideas. Hip arthroscopy is a hip preservation tool. We're looking to preserve someone's native joint, their native hip, by fixing things that are torn so it can have more longevity. A hip replacement is a reconstructive situation or a salvage procedure, where it's to say the joint has worn out to the point where it can't function as the patient needs, and it's interfering with their quality of life enough that they don't want to deal with it. And that's what a hip replacement would make sense. And so typically when you're talking about a hip replacement, you're talking about end-stage osteoarthritis or arthritis of any kind that has worn away the cartilage to the point where it's, as some people say, bone on bone, but basically so the joint is no longer functional. So two different mentalities, two different rationales, and they're used for two different situations.
Thank you. You spoke about it taking a while to get back going to what you were doing after you've had a hip arthroscopy. But are there any permanent activity modifications?
Not necessarily. Now, everybody has a different sort of, let's say, surgical experience for rehabilitation, but there's no prescribed activity restriction. I.e., we're not going to say you've had this hip arthroscopy and therefore you can't do X, Y, Z ever again. However, there is going to be a discussion with me before I graduate you about what it is you want to do with your hip. And every patient within themselves needs to have a conversation about, is what I'm doing worth the risk of this to me? Now, sometimes you don't have a choice. So if, for instance, somebody's livelihood relies on their ability to use their hip in such a way, then we want to make sure we optimize that, and they can't really step away from that. Now, the other question, though, is if there is a particularly high risk activity that somebody likes to do and it's not critical to their lives and they could do something else, well, we have a conversation. Well, could you not do that exercise? Not as much. Could you mix it up? So maybe that's not the centerpiece of what you do for your activity. And some people will say, no, doc, I'm going to keep on doing this forever. That's cool. But the important thing is we had a conversation about risk stratification. So I guess that's a long way of saying that, no, I don't necessarily restrict you from doing anything, with the consideration that we may have to consider changing how we do some things.
Thank you so much. That is all the time that we have for today. Dr. Owusu-Akyaw, would you like to close?
I want to thank you for taking your time right before a holiday weekend to come learn about the importance of hip mobility and how it pertains to global health. Let's continue to work on spreading the word and changing the way we think about sports injuries and focus on prevention over treatment best we can. Have a good weekend.